My name is Sarah Updegraff, and I am presenting on testicular torsion. Subjective information. The chief complaint is my left ball really hurts, my belly hurts, and I'm nauseous and throwing up. HPI includes, this is an 18-year-old white male who presents to the office with complaints of severe left scrotal pain, radiating to the abdomen, and nausea and vomiting intermittently for approximately 2 days. Nausea and vomiting started first and then has had 4 brief 2 to 3 minute episodes of acute scrotal pain, nausea, and vomiting in the last 48 hours that then resolved. The most recent acute episode started abruptly again about 1 hour ago and is unremitting. Denies fever or chills and states that he has not taken any medications. For subjective information, here is our focused review of systems. For GI, we've discussed the nausea and vomiting and abdominal pain, constant pain for the last hour, and denies all other GI complaints, diarrhea, constipation, indigestion, rectal bleeding. GU reports severe left scrotal pain and states that he has redness and swelling, denies all other GU complaints. For psychosocial, the patient reports feeling very anxious due to pain. Here is more subjective information, our past medical history. No relevant past medical illnesses. Surgical history is not relevant. He had tubes placed in the ears when he was about 2 years old. No past injuries and denies any recent injury to his groin. For psychosocial history, he lives at home with his parents, is taking classes at a local college, and works at a local grocery store. He denies alcohol or illicit drug use. Says he smokes cigarettes recreationally, less than 10 cigarettes a week, and reports that he is not normally anxious but is feeling very anxious today. No past mental health issues. For reproductive health, he is not sexually active and has no history of an STI. For allergies, there are no known drug allergies, but he reports seasonal allergies in the spring. He's not on any current regular medication, but occasionally takes acetaminophen. He takes Claritin for allergies during the spring, but is not taking at this time. And he does not have any contributory family history. So here is our objective information. This is our focused exam. Vital signs are relatively normal, slightly elevated respiratory rate. He presents as a thin white male, appearing younger than his stated age. He appears to be in acute distress, grimacing, guarding, breathing somewhat rapidly, and moaning. Skin appears slightly pale and slightly diaphoretic. Here's a picture of our guy who is not happy right now. So here's our focused exam. This patient had an unremarkable heart and lung assessment, other than that he had a slightly elevated respiratory rate. Abdominally was normal, except for that his abdomen is tender with radiating pain, scored 5 out of 10. For GU, all bladder issues were normal, no CVA tenderness or flank pain or bladder distension noted. The penis exam was normal. And now we get to the meat of our assessment here, our testes and our scrotum. So on the right, the testes was located on a horizontal axis. No edema, redness, lesions, nodules, or irregularities noted, and the cremasteric reflex was positive. On the left side, there was moderate scrotal erythema and edema. No lesions or nodules. The testes was located high in the scrotum and also located on the horizontal axis. 10 out of 10 pain, more severe upon palpation. Negative Pren sign. And the patient was unable to localize the pain in his scrotum. Appreciated a firm, tender mass located in the left scrotum above the testicle, and an absent cremasteric reflex on the left side. No blue dot sign noted. No lymphadenopathy noted. So here I'm trying to hone in on the fact that he's been unable to localize his pain. In a case of epididymitis, for example, I would expect it more likely that he could localize pain, or torsion of the testicular appendage. Generally, they can localize the pain. It's also interesting that both his testes are on the horizontal axis. So we'll move on to our diagnosis. So right now our diagnosis is acute testicular pain, nausea and vomiting, and abdominal pain. There's a long list of differential diagnoses, and I am not going to read all of these. The ones that are really at the top of my mind right now are testicular torsion of the spermatic cord, torsion of the testicular appendages, acute epididymitis, or epididymo-orchitis. Could also be incarcerated hernia, but we did not find any evidence for that in our physical exam. So I found this table in the peer-reviewed literature. This kind of gives a good breakdown of comparison of symptoms. So we've got testicular torsion, torsion of the testicular appendage, and epididymo-orchitis. So you can see our patient falls into the post-pubertal age group. Onset was acute. The site of maximal tenderness is diffuse. The cremasteric reflex is absent. And he also had a high-riding swollen testes. So index of suspicion is very high. Here's our diagnostic statement. He's an 18-year-old boy with acute, previously intermittent testicular pain, nausea and vomiting, and abdominal pain, who presents with an erythematous, edematous, asymmetrically palpated left testicle and an absent cremasteric reflex in the left scrotum. Here are our ICD-10 codes. The top three are the ones that I am working with right now. Torsion of the testes, unspecified, has to be confirmed through surgery or cannot be on a physical exam alone. So our number one suspect here is testicular torsion. You want to keep it in the forefront of your mind, especially because it is emergent. That is when the spermatic cord twists and obstructs venous return in the testicle, and it may result in compromised arterial blood flow and ischemia. Etiology, it is not often precipitated by an event, although it can be. Our patient did not report any traumatic event that led up to this presentation. It's most common during the neonatal interval or during puberty. Torsion can be extravaginal or intravaginal. Typically during puberty, it tends to be intravaginal, and the neonate is more extravaginal torsion. Venous return is obstructed first, and then as venous and arterial pressures equalize, ischemia results. The extent of the ischemia is related to the degree of spermatic cord rotation and the duration of the symptoms. That is why time is of the essence here. Intermittent torsion is possible and can progress to full torsion, and I think that is what is happening with our patient here. So do not delay referral. It's the most important thing. Time is testicle. And here is a picture of a normal testicle and then a picture of testicular torsion. You can see the spermatic cord twisted up on itself, and that is what causes the ischemia. So risk factors are the Bell-Clapper deformity, testicle with a horizontal lie, which our patient seems to have. A testicular volume increase can be caused by puberty, and perhaps this patient is a late bloomer, which is why he looks younger than he is, so maybe still having some issues with puberty. Testicular tumor, history of recurrent episodes of testicular pain. This is what he's reported having off and on over the last 2 days. History of undescended testes, or a long intrascrotal spermatic cord. So here's the prevalence and common symptoms. First is prevalence is 1 in 4,000 males under 25, or 3.8 in 100,000 under 18. I know those are pretty different, but those are they probably have different ways of measuring those. Common symptoms are basically our presenting symptoms in this patient. So let's talk about diagnosis. Careful H&P that suggests testicular torsion warrants an immediate referral. Diagnosis is confirmed at the time of surgical exploration. Practitioner may order a Doppler ultrasound only if it does not delay referral to surgery. Doppler and grayscale shows decreased blood flow in the torse testicle. And I've included a picture here in the screen where you can see the reduced blood flow in one of the testicles relative to the other, and that is a Doppler ultrasound. The ultrasound is also useful if you're trying to think about whether this patient has epididymitis or possible testicular infarction and epididymitis. You'll see increased blood flow on the affected side, and in testicular infarction, you can find a wedge-shaped avascular focal area. So this just gives us a little bit more information. In this case, he's pretty clear-cut. You're also able to do scintigraphy or dynamic contrast-enhanced NRI or radionucleotide scrotal imaging, but these are not often done because the Doppler ultrasound tends to be the most accessible, easy, fastest. And with labs, you will see an unremarkable urinalysis usually. And so something like epididymitis will not usually show a normal urine analysis. So that's another piece of information to think about for your diagnosis. So here's some evidence and guidelines regarding manual detorsion. Manual detorsion can be attempted in addition to prompt referral. The guideline from Essential Evidence says that you can attempt detorsion to help support your diagnosis. If detorsion relieves pain, then that is pretty indicative of testicular torsion. Hollier recommends manual detorsion if surgery is not available in fewer than 6 hours, and Dynamed Plus recommends manual detorsion only if it does not delay surgical treatment. Sharp and Kieran is another article, and they are the same as the Dynamed Plus guideline. Here's our management plan. So we've got our working diagnosis, 1, 2, 3, the plan for medications. Pain control for testicular pain and abdominal pain would be part of the plan. Oftentimes, pain is reduced after torsion is corrected surgically, but you can use a local anesthesia if you attempt manual detorsion. And you can give analgesic medication for pain or antiemetics for nausea and vomiting, although this is not generally done in the primary care setting because you're trying to get them to emergent care right away. So these are two algorithms you can use for evaluating acute scrotal pain. So we'll start with this one here with a history of recent trauma. No, he did not have recent trauma. Cremasteric reflex present. No. Then this is where they suggest manual detorsion resulting in immediate relief of pain before urologic consultation. If it does not result in immediate relief of pain, you can do a Doppler ultrasound if it doesn't delay treatment. Here in the Sharp and Kieran algorithm, if the history and physical is highly suggestive, you just refer them out. If it's got a questionable diagnosis, that's really when you're going to be doing the Doppler ultrasound. For referral and follow-up, you're going to have your immediate referral. Surgery is the only definitive treatment. And the follow-up plan is to see your urologist in 1 to 2 weeks post-surgery, annual wellness visits checking GU health, and patient education to seek care immediately if symptoms reoccur or if there are signs and symptoms of infection post-op. For health promotion prevention, there's not a whole lot because there are really no lifestyle changes you can make or ways of preventing this. There's no complementary therapy, diet changes, OT, or PT. Mostly what we're going to be doing is patient education. So for patient education, you're going to be doing some counseling about the potential need for orchiectomy and information regarding the fixation of both testes, what to expect, possible issues with future fertility, atrophy of testes at the time. And you're going to do all this at the time of informed consent. You will also be discussing risk factors and complications. For example, our patient has a bell clapper deformity, so he should know that he's at higher risk, and be aware that even though they may salvage the testicle, 66% can show atrophy in 2 to 3 years. So to be on the lookout for signs and symptoms of that. Mostly he needs to be aware of early recognitions of sign and symptoms. We'll want to discuss his prognosis. Salvage rate is 90% if within 6 hours, 50% within 12, and less than 10 after 24 hours. Since it seems he's had kind of an intermittent torsion path into a full torsion, I would guess that his prognosis is probably going to be pretty good since he's only had acute symptoms for an hour. He'll want to be aware of any complications like testicular ischemia, impaired fertility if he does lose a testes, recurrent torsion, and psychological distress that can be caused by that. Here are our treatment guidelines. There's a list of resources here, and then basically all the guidelines recommend emergent referral to the ED, urology, or surgery if testicular torsion is suspected. All guidelines also recommend Doppler ultrasound or any other imaging tests only if treatment is not delayed, and really only if you're not sure of the diagnosis. So this is an example of an order for a Doppler ultrasound. I would not actually order a Doppler ultrasound in this case because our patient seems pretty clear-cut, high-risk case for being testicular torsion. I wouldn't want to waste time. I would just want to get him there. But this is an example of what that would look like. And at any rate, he could end up having a positive or negative ultrasound result. If it was intermittent torsion, it doesn't always capture it, and that still would be a referral. So regardless, even if I did an ultrasound that didn't come up positive, I would still refer him with the symptoms that he has, which is why take time to do one. All right, and then here are my references. Thank you very much. This is an 18-year-old. Is Sarah Updegraff. And I am presenting on testicular torsion. Subjective information. The chief complaint is my left ball really hurts, my belly hurts, and I'm nauseous and throwing up.